Very well. So what he is describing, what he was describing were the difficulties with the pulmonary veins. He had the circular catheter in the upper vena cava, in the right vena cava, and he was trying to do an ablation in the posterior aspect of the right superior vena cava. As Chief taught us, I believe that all these explanations have been described in the literature. This original description by Kidd and Fleck dates back to 1907, and he described then the connections between the atrium and the ventricles. The original description is very simple. The muscle fibers surround the posterior wall of the pulmonary veins. The right pulmonary veins connect directly through the superior vena cava and the inferior vena cava with the posterior wall of the right atrium. And this causes a direct connection between the right atrium and the left atrium in the posterior aspect of the heart. So when we think about the right and left atrium, you cannot think of them as two separate structures. In fact, it's one single structure, and let me show it to you in a minute. Let me give you an example with a clinical case. This is a patient undergoing a broad circular ablation for atrial fib, and the patient came for No, I'm sorry, this is not the right presentation. I have to switch. When you look at this connection with McAlpin's diagram, which in my opinion is the best anatomical representation, this dates back to 1907. This is an intact heart. When you look at the posterior wall of the right atrium, the inferior vena cava, the superior vena cava, and the pulmonary veins, this is a uniform connection between the posterior wall of the left atrium and the posterior wall of the right atrium. So what Dr. Natale was trying to describe is that he had difficulties to isolate the left pulmonary vein. He had a lasso in the superior vena cava, and this is why, in my opinion, many times the isolation of the superior vena cava improves the outcomes of atrial fibrillation because we get better disconnection of the right veins. Let me show it to you in a while. He's doing ablation here to try to isolate the right veins. So all of this has an explanation. Let me show you a case. This is a patient who came for recurrent ablation of atrial fibrillation, but mostly flutter following pulmonary isolation. The first step we do when the redo is started is to check the pulmonary vein. This patient with a recurrence of flutter and AFib after one procedure comes the lasso, the circular catheter. We have the right veins, and in sinus rhythm, you can see that the right veins are connected. We disconnect the right veins. Prior to disconnecting the right veins, we check the left veins, and the left veins are totally disassociated. We do a voltage map, which is my favorite when I have to do a redo, trying to identify what was done in the previous procedure. We clearly see that the left veins are disconnected. There is a line on the roof. There is an anterior line. We don't know whether there is blockade or not. And the lower veins particularly seem to have a little bit of entry, and they are not disconnected as we saw before. So in this case, we showed that there is bidirectional blockade of this line. So most likely the relapsing flutter is not mitral. We paste on both sides, and here the catheter shows the broad disassociated potentials, which suggest blockade of the line and pacing of the septal region, then pacing of the circular catheter, and then finally the catheter pacing. So all lines are connected with the exception of the lower one, and the mitral line has a blockade. Why is there a relapse? Well, the veins are connected. Apparently, this is the septal aspect of the left atrium, we disconnect the vein, and after disconnecting the vein, a flutter is induced, which is normal at 370 milliseconds. So this line, which apparently was blocked, is probably not blocked. So we do entrainment of the proximal coronary sinus. That's outside the circuit, as you can see. We do entrainment of the distal coronary sinus, and it's outside the circuit. So probably it has nothing to do with the coronary sinus. What's interesting is that we do entrainment of the catheter in the posterior aspect of the right atrium. And look at what happens. The posterior aspect of the right atrium, over here, we do the entrainment, and it's inside the loop. This slide, I just show it because one of the basic concepts when you do ventricular entrainment is that you are trying to identify the right entrainment, not just the PPI. Not just the PPI, there has to be concealed fusion as well. And in the atrium, very often we don't see the piece, we forget about everything, and the only thing we do is to see the PPI. But if you look at the piece when you are doing entrainment, in this particular case, you realize that if this were ventricular tachycardia and you see the P here, this P is exactly the same as the tachycardia P. So not just the PPI is correct, but you also have concealed fusion, and the intracardiacs are exactly the same. So you have concealed fusion in the in the ECG, and concealed fusion in the electrograms with perfect PPI. This means that the posterior aspect of the right atrium is part of the circuit. At this point, we have the lasso in the lower pulmonary vein. And we have a potential in the lower pulmonary vein, a vein which was apparently disconnected. And this is very important because this is the first point where most people that don't believe in these says that you are crazy. Why? Because you are connecting directly. The key to prove that connection is not to pace from the septal aspect of the pulmonary vein, but rather to pace from the posterior aspect of the pulmonary vein. Because people say that if you are in the septal area, because of direct continuity, you can capture. But if you are in the posterior aspect, that shouldn't be direct continuity. When pacing from the posterior aspect, once again, we get a perfect PPI. And not only that, just look at the P wave. The P wave captured is exactly the same as the P wave in tachycardia. And the steam to P wave, which is another component for pacing, is extremely long. In the previous case, when we paced from the right atrium, it was very short. So if you are considering re-entry mechanism, the right atrium is the exit, the left atrium is the entry to the circuit. So you have the entry in the right pulmonary or the exit in the right atrium. So this is a circuit that goes from the right to the left atrium. How is that possible? Well, clearly, when we realized that there was a vein connected, we decided to isolate the pulmonary vein again. When doing so, the flutter ends, but the vein continues to be connected. And this is what was happening to Andrea in the lab. They couldn't disconnect the right vein. So what can you do? Which are your options? Well, the options are to enter once again into the vein or look for the exit. And this is the second concept, do an activation mapping of the outflow or the exit of the pulmonary vein. And when you see the pacing from the pulmonary vein, there is a very long pathway, and then we look for the earlier area, and you realize that the posterior wall of the right atrium is earlier. So what do you do in that case? Ablation within the pulmonary vein, more septal ablation to the left, but often the more septal ablation to the left side is limited by the phrenic nerve. That's what Andrea was explaining. Or map the exit and look for the connecting site. Option number one, from my opinion, is beyond the scope of the discussion because there is no reason whatsoever that a patient with atrial fibrillation to have a risk of pulmonary stenosis. So personally, I never work inside the pulmonary veins. If I can't work because of the risk of the phrenic nerve, what I have is the physiology from electrophysiology, and it has to be combined with the anatomy, and that's exactly what I am going to show you. The key is to do activation. And this is the activation. What's important here is to understand the map and the pacing or activation. This is the right vein. This is a reconstruction of the right atrium. When I stimulate the posterior aspect of the lower right vein, I look for earlier activation, and this is where it occurs. It's not in the septum. It's in the posterior lateral aspect of the superior vena cava or the lateral posterior aspect of the right atrium. And by doing ablation in this area, you will see what happens. This is just to show you stimulation or pacing of the inferior vein or of the lower vein, right atrium and flutter. The pace map of P wave is perfect. The pulmonary vein, long steam to P wave, and then short steam to P wave. Entry and exit, clearly proven. So essentially, we are showing the same here. Let me skip over this. And here we see ablation in the posterior aspect based on activation. It has to be based on activation. Why? Because the anatomy and the exit is different in every patient. Each one has a different anatomy. The anatomy of this patient is different from another patient, and you have to reconstruct the anatomy to understand it. If you do the ablation here, there is total isolation of the right superior pulmonary vein. And this is key because you can spend hours on the left side and you will never get this result. This is another case, which is very important because I believe that this is one of the most important reasons of concern. This is a paroxysmal patient, and the superior right pulmonary vein triggers atrial fibrillation. When you isolate the superior right pulmonary vein, the patient develops sinus rhythm. What happens if this patient recovers the exit of the pulmonary vein? Will he experience atrial fibrillation? Well, the patient had an entry block, but there was no exit block. In our laboratory, and I am sure that it's different in other laboratories because not everybody does the same thing. The endpoint of pulmonary isolation is blocking the entry and the exit. If I pace over here, I can see that there is an inflow block, but now there is no exit block because the penta-ray probably is very close to the right atrium. No, there is a proper distance between the pacing of the vein to activation. An earlier activation, this catheter, which is localized in the left atrium, and this is the way to make the diagnosis. You place a catheter in the left atrium of the atrial side of the ablation line and the right atrium. If the right atrium is earlier than the left atrium, the exit is through the right atrium. This is very simple to do. This is what we did in this patient. We did the mapping, the earlier activation in the posterior septal segment and doing the activation mapping. This is the earlier site, ablation in this area, total isolation of the vein, and we prove it during stimulation. We are pacing the penta-ray. It captures the penta-ray, and when reaching this point, the exit is totally blocked. The exit was through the right vein and not through the left vein, and that's what they were trying to explain. So basically, we are talking about these connections over here. And the reason why this happens nowadays, in my opinion, and I would like to discuss this with Shiv, with Dr. Eisberg, with Andrea, with everybody present, is this idea which I just showed you. These connections were described in 1907, and it was clearly described by McCulpy, but the prettiest image by McCulpy is this one. This is the connection. What I am trying to draw here is an ablation line. The broader the ablation line, The wider the ablation line, that line will go through the posterior wall in the pulmonary veins. But when it comes down in the septal aspect of the pulmonary veins, all this area remains with no ablation. So what happens? 10 years ago, when we did osteal ablation inside the vein, this is where we did the ablation. Now, we are losing this connection and we are paying more attention to the phrenic nerve. If the phrenic nerve goes through here, we don't do ablation, we broaden it. And that's why it's important, because we will see this more and more frequently. This is something we published in 2014. We had 5 patients then. Now we have like 15 where we do electroanatomical mapping of the bundle. And the editorial of the paper is fantastic because it describes, based on Sam and Dr. Stevenson, the multiple connections existing in the atrium. For instance, what we did today with the vein of Marshall. This is a connection between the atrium, the epicardial atrium, and the endocardium of the left veins. And basically, this is the way to do it, and it is described in the paper. So to determine that the earlier site is in the right atrium and not the ostium of the vein, to make sure that it's not due to continuity, so you have to pace the posterior wall of the pulmonary vein and not the septal wall, and make sure that it is not far field, and pace looking for the earlier site with no direct capture of the superior vena cava. And then the ablation is based on the earlier activation that is usually here in the posterior wall of the right atrium. And I think that this is extremely useful when you experience difficulties in isolating the right pulmonary veins. Thank you very much. Any questions? I'm sorry, there is no microphone for questions. I think it's a low incidence, probably 2 to 5% of cases. But I believe that the incidence is low because we don't recognize it. Sometimes you end with a pulmonary vein or you are not sure. Some people don't check the outflow blockade. So many people just don't see it. I agree with you, the incidence is low, but I think that in a patient with triggers of the right vein, psychologically, I have to make sure that there is no exit through the right atrium. And most of the time, you're very right, Alberto, we don't find it. We don't identify, but if you don't look for it, you will never find it. And whenever you have difficulties in isolating the right veins, I'm sure you have had at least one case, usually the response or the answer has been place a catheter on the carina. Of course it works, because if you place the catheter in the carina, you are isolating that fiber that crosses from one side to the other. But sometimes I place the catheter in the carina, I do 2 to 3 lesions and I don't get any results. So I have to do 3 or 5 lesions. If you have one single case of pulmonary stenosis, that's a terrible experience. So for me, the message is, yes, this is rare, but it will happen. And it will happen more frequently with the broad ablations, and instead of doing something which is counterproductive anatomically, which is to burn inside the vein or to damage the phrenic nerve, is to map the exit and to burn in the posterior wall of the right atrium, where usually you don't have a phrenic nerve. But I agree with you, this is a rare condition. It's unusual. But that's the way to do it. And the anatomic explanation of why this happens. Well, half of these patients were before contact force and the other half was after contact force. It has nothing to do with isolation, and you can see it after you do properly the line. I think that more contact force is due to the broad ablation contact because you are not targeting so much the septal aspect of the right veins. Today with contact force, we just continue to see it. A question, Fermin. You say that you don't burn inside the pulmonary veins, but what happens if you isolate the pulmonary vein? Well, personally, if it's focal inside the pulmonary vein, I don't burn inside the pulmonary vein. My approach is to isolate the pulmonary vein because sometimes you're lucky and it's just one site. But if there is any change, what are you going to do? Then you have to do 10, 20 lesions, you get edema, and you no longer know what is going on. In the past, we did focal ablation inside the pulmonary vein. I think that today we would isolate that segment of pulmonary veins. That would be the response. Obviously, you have to be extremely careful because that means that if there is one single reconnection on the line, you will have a relapse. So probably it's better to do the focal ablation from the viewpoint of the outcomes. If it is one single lesion, I think everything would be okay. But a tachycardia of the pulmonary vein will sooner or later result in atrial fibrillation. Maybe you can do the focal ablation, but there is also pulmonary isolation.
It depends on age. If it is a 20-year-old patient, I only do the arrhythmogenic veins. If it's a 45, 50, 60, I do all the veins. That's what I personally do. I don't know if somebody has a different comment. Está repitiendo la pregunta porque no se oyó para la traducción. The course of the phrenic with diaphragmatic stimulation. When you're going to do these types of applications, although I know you're going to be posterior and theoretically there wouldn't be much of a risk, do you do all that marking or do you go directly to the application? Do you do the demarcation? Well, the question, if we do the demarcation of the phrenic nerve here and we decide that we need to apply here, we go again to look through the phrenic, but usually for any reason, if it's here and comes this way, usually this area is an area where you don't see the phrenic nerve, but I do again an activation map of the phrenic nerve in the right atrium, of course, because if you damage the phrenic here or here, it doesn't matter. You're still damaging it. But usually it is more lateral because it goes down this way. It doesn't come down this way. Remember that the phrenic nerve doesn't go towards the septal portion of the IVC. It goes through the lateral part of the right atrium. So usually this space here is a space where you can do ablation. This is a space where you're going to find the phrenic in the right atrium, but since all patients are different, we do the anatomical reconstruction, and I look for the phrenic nerve in the right atrium before we do the pacing or the stimulation, or we place the decapolar, we stimulate up there, and you evaluate the phrenic nerve while you are doing the ablation.